seniors, friends, and students. Warm, very good morning to all of you. And at this juncture, expressing my sincere thanks to our Preeti Hospital Administration, Dr. Sukumar Sir, Hema Madam, and our Preeti Anesthesia Update team, Dr. Balaji and Rishwesh, for giving me this wonderful and nice opportunity. And coming to the topic, Costoclavicular and the infraclavicular blocks. I think these two blocks are most commonly ignored by the majority of anesthetists, including myself, because we are thinking that this is somewhat a technically difficult one to do, and at the same time, we cannot give you a complete anesthesia for the upper limb, as though in your supraclavicular blocks, so-called the spinal anesthesia of the upper limb. But this is not so. And one thing I can assure you that so far you have scared about all these anatomies and all the vascular structures and all the stellate ganglion and everything, recurrent nerve, phrenic nerve, and you have no need to worry about all these in these two blocks. Only problem is your needle visualization. If you do in a better way with your ultrasound techniques, you can very safely you can do these techniques. So happily you can go for another 20 minutes. And first you must know always as an anesthetist you know the anatomy of your brachial plexus. And if you know it well, you can see if you are going blocks above the clavicle, you are having your dorsal scapular and your long thoracic nerve and your suprascapular and the nerve to subclavius. These are the four nerves which has been emerging above the clavicle. So if you see all these nerves may not be necessary for your perfect upper limb anesthesia. You may need occasionally, as you said, the suprascapular nerve for anything for your shoulder joint only. Other things you can jolly well you can go with blocking all your blocks at the level of the infraclavicular, that means at the level of the cord level, and you can give the complete anesthesia as though you were spinal, that is as though you were supraclavicular blocks. There is no need to worry about this. And coming to the infraclavicular anatomy, this is very simple, divided into this infraclavicular areas divided into medial infraclavicular fossa and the lateral infraclavicular fossa. And this medial infraclavicular fossa extends from your lateral border of your first rib cranially to the middlemost border of your pectoralis minor muscle. So this is the medial infraclavicular fossa where you are going to target the cords at the level of your costoclavicular space. And second one is your lateral infraclavicular fossa. It lies exactly deep to your pectoralis minor muscle, where it is related to your second part of the axillary artery. So this is our first focus of interest, where the costoclavicular space, where the cords are lying lateral to your axillary artery. And this is the lateral infraclavicular block, where you are going to focus on your cords which has been spread around the axillary artery. So lateral to what happens, the lateral to the first rib, the 6 divisions of the brachial plexus regroup to form the 3 cords. So our job is very easy. It becomes a uniform group. So these cords enters into a costoclavicular space, and it lies between exactly the middle third of the clavicle and the second rib. So Dr. Karmakar, he is a pioneer in regional anesthesia. He has described this as an anatomical sweet spot for targeting the brachial plexus. So it is a very sweet spot. You can target the brachial plexus. So coming to the zona anatomy, very simple. So you have to target the pectoralis major, subclavius, which was very well demonstrated by Dr. Gurumurthy sir. So pectoralis major, subclavius, axillary artery, and easily you can see all the 3 cords clustered together lateral to the axillary artery. So before going for exact target window, you must know all the adjacent zone anatomy also. You must know little bit scanning for that. So you have to go for a medial infraclavicular fossa scanning for that. So you can go in 4 steps. The first step, you can go like this. You can put your probe on the clavicle. you cannot see any shadow. You can see only the acoustic shadow. So behind that, you cannot see any tissues. And if you go a little bit, just slip down from the clavicle, if you direct it careful, this is your target zone anatomy, where you can see the axillary vein is the middlemost part, and one is the axillary artery and your cluster of three cards. And if you move a little bit downwards, you can see only the cephalic vein. So here not much of vascular structures. You can see the cephalic vein. It comes from lateral to the medial and it's joining the axillary vein just over the axillary artery. So this is, if you are seeing this window, you can better avoid this, you are putting your needle, because you may injure the cephalic vein when you are going to reach the cards. And if you come a little bit further down, you can see the thoracoacromial arteries. So you have to remember only these two vessels. One is cephalic vein, another one is the thoracoacromial artery, so which is emerging from your axillary artery. This is first part of the axillary artery. So even if you are going this, you can see some of the cards here, but better you cannot manipulate in this window also. So knowing this, you can go to your target site. There is a second place just immediately just below the clavicle. You can focus on like this. You can have to have little bit careful. You have to go just behind the clavicle, and you have to reach your target zone anatomy. There is your axillary vein, axillary artery first part, and your three cards. So if you targeted this your zone anatomy, then you can you can put a needle from the lateral to medial direction in the in-plane technique. So always you have to see the tip of the needle. Always you have to see your subclavius muscle. That is most important when you are putting the needle. And if you reach between your lateral cord is the most anterior-most part. Just below the lateral cord is the medial cord. Lateral most is the posterior cord. This is the arrangements. Usually these arrangements may not have any variability. So if you go from here, if you are going just reach between the posterior cards and the lateral cards, you can give all your local anesthetic at least about 20 ml. You can block your upper lip. So what are the advantages? So the cards are very superficial, exactly just passing from your brachial plexus in the supraclavicular area, and it is clustered together around the axillary artery. This anatomic relationship is constant. There may not be any variability. Always they are clustered together. Always they are lateral to your axillary artery, and all the three cards are visualized in a single window. So there is no need to go for upper trunk, no need for lower trunk. So here we can have a single window. You can see all three cards. Single injection, you can deposit all your local anesthetics. So as I said, even you can go lesser than the 20 ml of your volume. The answer will be very fast. There is no need to wait for another 10 minutes or 20 minutes here, because all are clustered together. So if you are going to give the drug, it acts immediately in all the three cards. You can give the complete block in a short time. And one more advantage is you can put a stable catheter placement here. And apart from that stable catheter placement, there is one more advantage is you can have a very good secondary block success rate. That means even if you are going to put a catheter in between your lateral cord and posterior cord, if you are going to give after the surgery, if you are going to give a post-op analgesia like 5 ml per hour or something local anesthetic with your narcotics, then that 5 ml is completely will spread over all the three cards. So the analgesia will be complete, which may not be in other blocks, especially even in your lateral infraclavicular block. And it is much away from the pleura. If you target properly, then you cannot damage the pleura, and always there may be sparing of phrenic nerve. Occasionally the phrenic nerve may be get blocked if you are giving little bit over dosage of your local anesthetic. Otherwise the phrenic nerve may be spared. And disadvantage is very, very less. As I said, you have to focus on your thoracoacromial artery and the cephalic vein. And sometimes there may be a septate between the lateral and the other cards. So at that time you have to give two injections, one just below your lateral cord and one just above the lateral cord. And there is an argument that since it is doing below the clavicle, your suprascapula nerve is spared because there is no way coming in the infraclavicular area. But there is a dye distribution study done by again a pioneer in regional anesthesia, Dr. Sandeep Diwan. he has found that the suprascapular nerve routinely stained. If you are giving a stain in a cadaver in the costoclavicular space, it spreads upwards and even it stains your suprascapular nerve. So even then, if you are going to give a costoclavicular, it will almost acts like your supraclavicular brachial plexus plus by blocking the suprascapular nerve. And one more trial is there. It gives adequate analgesia after the shoulder arthroscopy surgery also. So that is again definitive indicator of blocking your suprascapular nerve. So I will come to video later. So this is the lateral infraclavicular fossa. So this is just behind your pectoralis minor muscle. So this is a pectoralis minor muscle. Just posterior to that, your second part of axillary artery is there, where the three cords are hugging almost the axillary artery. And this is the zona anatomy. This is your targeted zona anatomy for your lateral infraclavicular block, where all the three cords surrounding the axillary artery. So in the costoclavicular space, they are almost clustered together. Here they are separated each other. So lateral cord, posterior cord, and medial cord. So if you make it as a clock, the lateral cord is around the 3 o'clock position or 3 to 5 o'clock. Posterior cord is in the 6 o'clock position, medial cord is in the 9 o'clock position. But before going to such your zona anatomy, this is a very simple and challenging technique. So simple in the means the identification of artery. Just you have to put your probe and you have to identify the axillary artery pulsation. That is almost simple. And challenging is because little bit deeper, it almost goes up to 4 centimeter. And if you are going to put the needle, the angle of approach is more acute. So your visualization of the needle and the target axillary artery is little bit challenging. Or otherwise, definitely it may be a very good easy technique to do the block. And apart from your target area of your zona anatomy, you have to scan little bit up and down. And before scanning, you have to position the arm in abduction. That is most important for in both costoclavicular as well as your infraclavicular block. And if you do the abduction, the depth of your placement of a cords is reduced and also elevates your latter part of the clavicle. So the clavicle comes away from your area of injection. You have the little bit area over putting the needle between your clavicle and your probe. And you have to put the probe just medial to the coracoid process and just inferior to the clavicle. You can use either a linear or a curved linear probe. And you can, if you are after putting a probe, as usual, you have to try to look for the axillary artery. You tilt, slide, or rotate, and you try to visualize your axillary artery. And again, it's not easy to identify all the three cords as I shown in the pictures on anatomy. You cannot always see the cords, and you no need to see the cords also. You see the artery properly and avoid this type of images. That is, you can see the pleura here. If any images like pleura coming into review means that is you are little bit medial. So you are near the chest wall. So if you saw, you have to just little bit come laterally and you have to come to the proper location of the axillary artery. Even if you are go little bit lateral, suppose you are avoiding the chest wall, you are coming laterally. If you are going laterally, you can see the coracobrachialis muscle just lateral to your axillary artery. If you could appreciate this coracobrachialis muscle means, then the musculocutaneous nerve has been already taken off. Then if you are going to block at this level, the musculocutaneous nerve may be spared. So that's why you should not go too medially to view the pleura, should not go laterally to see the coracobrachialis, and you put a proper your probe in a proper place to look the axillary artery. Don't try to look for all the cords, and put your needle from your Kevlar to caudal and try to reach your 6 o'clock position. That is the target area you have to reach. This is the only difficult part when you are going to inject. So if you are little bit careful enough, if you are going to do in a better way, definitely you can reach the 6 o'clock position. If you deposit the drug of local anesthetic around 30 ml, if you are having a spread like this, definitely the block will be 100% will be taken. So you have some tips and tricks to get that become a successful one, that means you have to need the needle have better visualization. So sometimes you may need a echogenic needle, you can avoid the conventional needles, and the hydrolocation. So when you go, if you want to see the tip of the needle, if you are going in the deeper brain, as Ganeshan said, you can go for a hydrolocation, and for the hydrolocation, you can use either dextrose or normal saline. You can avoid the local anesthetic. Even if you are using a local anesthetic, try to look for a identifiable hypoechoic. So if there is no any hypoechoic lesion arises there, then that means chance for the intravascular injection may be there. So try to hydrolocate, try to see the tip, and try to reach your target area. And if there is any difficulty in identifying your artery and vein, definitely you have to use your color Doppler, and because the compressibility may not work out here because it is a little bit deeper. Otherwise, if it is a superficial one like axillary or supraclavicular, you can easily go for a compressibility. So once you inject the drug, it has the U-shaped pattern. Definitely the block will be a successful one even with a single shot injection. There is no need for multiple injection like in your supraclavicular or in a interscalene. And one more clue to your injection is a double bubble sign. So when you are putting a needle at the 6 o'clock position, if you are able to, you have to inject 2 to 3 ml of your local anesthetic. You can able to appreciate your local anesthetic as a bubble, and if above the bubble is the axillary artery, so if you are able to see both these hypoechoic bubbles, then that is a very good placement of your needle. If you are going to inject the remaining amount of local anesthetic there, the block will be taken adequately. Because if you are going to give adequate doses, all the cards will be separated from the axillary artery. Actually, all the cards will be hugging your axillary artery. It almost looking as a white wall. It's almost looking like a white wall. So if you are going to give a drug, it is going to separate between the cards. That is called a white wall sign. Another one is a dog stripe sign. So if you are going to put all the local anesthetic, if you are going for a long axis view, you can see the axillary artery, and posterior to that you can see the local anesthetic spread, and beyond that you can see your posterior cord. That is your local anesthetic spreading your posterior cord and your axillary artery. That is called dog's type sign. By this you can confirm your local anesthetic spread. And one more advantage unique with both the costoclavicular and the lateral infraclavicular block is your catheter. So you can place the continuous catheter. Again, the target location is your 6 o'clock or 7 o'clock position of the catheter. Remember that you should not advance the catheter more than 3 centimeter. So just thread the catheter 3 centimeter enough beyond your tip of the needle, and you can check the catheter with injecting a local anesthetic, and it gives a very good stabilization of the catheter. So it prevents all these going through the deeper brain, through the pectoralis major and minor muscles. The catheter dislodgement rate is very, very less. And one more technique you have to learn is the looping of the catheter. That is, you are placing the catheter at the 6 o'clock position. You are confirming your catheter position by injecting the local anesthetic. And under revision, you slowly withdraw the needle up to your first pectoralis minor muscle and try to thread 2 to 3 centimeter of your catheter inside the muscle. So that may form a loop in the pectoralis minor muscle. And again you withdraw the needle under revision up to the pectoralis major. Again try to thread 2 to 3 centimeter of your catheter. Again that may loop in the pectoralis major muscle. Then you withdraw the needle completely, so that all the loops inside the muscles will have a very good stability for your catheter. It may prevent your dislodgement again. Because we could try a lot of cases under the catheter. So even for the shoulder surgery or anything else, we have gotten infraclavicular or the costoclavicular. The common complaint we are facing is the catheter dislodgement. Because surgeon வந்து என்ன செய்வாங்க, கையை தூக்குறாங்க, அது பண்ணுறாங்க, ப்ரீவாஷ். ஸோ எல்லாம் முடிஞ்சு நம்ம சர்ஜரி முடிச்ச பிறகு பார்த்தோம்னா, if you put your sonogram and see the catheter to come out. So if you do all the techniques, you can prevent the catheter dislodgement. And advantages, so even though the patient is not able to abduct, actually better if you do in a abducted position, but even if you are not able to do in a abduction, even in the adduction position, with the patients with the pain or cast, with the patient having without having a good anatomy in the axillary area with axial dissection, where the axial block is not feasible, definitely you can go for a lateral infraclavicular block. And all the proximal arm muscles supposed to be blocked as like though in your supraclavicular block. There is a wonderful tourniquet tolerance with this infraclavicular block. We may think that the patient may not have a adequate tourniquet block, patient may not tolerate adequate tourniquet block. But here the patient may tolerate the tourniquet wonderfully because the tourniquet tolerance depends upon all your anesthesia muscles only. And even then if you are having the extra blockage of your intercostobrachial nerve. So here the intercostobrachial nerve comes from the T2 and its course traverses almost near your second part of the axillary artery. So if you are going some amount of your drug is going and the spillage over your intercostobrachial nerve, even intercostobrachial nerve gets blocked. And advantages again, phrenic nerve paresis. So almost may not have any phrenic nerve palsy. Risk of pneumothorax reduced. If you come out of your pleural window, definitely your pneumothorax will be reduced. And still now there have been no reports of any recurrent laryngeal paralysis with your lateral infraclavicular block. And you can put a continuous perineural catheter placement. As I said, the secondary block success rate with this lateral infraclavicular block is little less because you are putting the catheter in the posterior cord position. And if you are going to give 4 to 5 ml per hour, then naturally it may spare your medial and the lateral cord. So that is why the posterior block's success rate is very high in a costoclavicular block rather than your lateral infraclavicular block. And disadvantages, again it is deep and covered by both pectoralis major and minor muscles. And if so, you may need a low frequency, small curvilinear transducers. Here, the position of the cords is variable. So if you are doing an abduction or adduction, the cord position, as I said, 3 o'clock, 6 o'clock, 9 o'clock positions are variable. You have to be little bit careful. But if you are abducting, adducting, the costoclavicular cords may not have any variability. The cords in the costoclavicular space will be almost stable and it may not have any variability with the change in the position of your arm. And as I said, if you need it, you can go for a echogenic large bore needle. You can for a better needle visibility. And if the patient having any extremely, they are having any chest deformity or any healed clavicle fractures like this, if your anatomical orientation is difficult, then chance for risk of pneumothorax may be there. This is the costoclavicular block, where you can see the axillary artery. So this is the bunch of your cords where you can put your needle. After putting your needle, even you can see the cords very well. This is lateral cord, medial cord. So this is lateral, this is the medial cord, this is the posterior cord. This is the exact arrangement in your costoclavicular block. It's very easy. Once you put very superficial only, need little bit your transducer orientation underneath the clavicle. You put a needle and you can block very easily. This is your pectoralis major, this is your subclavius. This is the infraclavicular block. Actually, we did it only yesterday only for the demonstration purpose. So we have used an echogenic needle. You can see the easy visibility of the needle. It just goes and lands over your 6 o'clock position. So this is the double bubble sign. So you can see the axillary artery. So if you are going to give some drug here, see the space get expanded. You can see the 2 bubbles. You can see the double bubble appearance. And after that, if you are going to give all the drugs, it is going to spread both sides of the artery very well. Even it is lifting your axillary artery. Thank you. Once again, my sincere thanks to the Preeti Anesthesia Update team for giving this wonderful opportunity. I think, as I said, it is a most ignored block, and if you follow the anatomy and if you constantly doing, you may not care about all the interscalene and the supraclavicular blocks. You can easily do this both the lateral infraclavicular as well as the costoclavicular approach in a very easy way. Once again, thank you for the opportunity.
Sir, you have told us about the septum in between the lateral cord and the posterior and the medial cord, sir. So, is it always present? It is always advisable to go for a two-site injection or a single-site injection is enough, sir?
Single side injection is enough. If you are seeing that, you can easily see all the three cards will be separated. Even you can here see, even we have manipulated the needle somewhat, but the drug is uniformly distributing all over the cards. So by visualization, if you are having any delineation of your cards, that is usually it is lies between your lateral card and the middle card. So lateral card is the anterior structure. So if your lateral card is not visible, it is not coming out, just with the needle, just behind your lateral card, and you deposit another 5 to 6 ml of drug. That's enough. Septa is there, but it not always in both, as well as in the costoclavicular as well as in the lateral infraclavicular.
Regarding
Actually, lateral infraclavicular, some of them going for a triple injection. Since the cord is separate, they are going to inject from the top of the axillary artery. They are going to block your axillary artery, middle cord, and again coming back to your 6 o'clock position, your lateral posterior cord, and again they are blocking the lateral cord at the 2 o'clock position. But that is not much warranted. So just to put your needle at the 6 o'clock position, you put enough drug, that is 30 to 35 ml of your local anesthetic. That's nice.
Sir, risk of pneumothorax, sir. We can see, sir, the pleura is very much closer. Any incident, sir?
I think recently with our ultrasound, the risk of pneumothorax, even in the supraclavicular, is almost nil. But it happens in hands of the novice. So if you are a novice anesthetist, if you are doing first time or second time, if you are not able to see the needle tip visibility, naturally occurs. Or otherwise, definitely 100% you can see only pleura wherever you are going, definitely you can avoid. It is always well away, not like in the supraclavicular.
Thank you, sir. Thank you very much, sir.